Should we wait for 1-2 minutes?
It's up to you.
Okay, Mikna, are you here?
Yes.
Yes. So I did not forget about the narrow QRS tachycardias. Maybe we will talk about this on Friday just to prepare some slides and to know exactly what we are talking about. And we gave up the idea with your presentations with medication and so on, because we have plenty to discuss. So here we are for some prevention slides. You talked in hypertension maybe, or in cardiovascular risk factors, about the score charts, score cardiovascular risk charts. Do you know what these charts are useful for? Did you see this image before? Yes, no?
Yes.
Okay.
Semiola.
Okay, so these are the charts that let us know about estimates the risk of patients. And we know we have some developed charts for every region, for every country, so we must know exactly what to choose in order to estimate the risk of a patient. And these charts are based on some parameters, sex, age, cholesterol level in millimoles here, but we have the transformation here, systolic blood pressure, and the status of non-smoker or smoker. So we must estimate the risk for every patient based on these parameters. And you know that this one here, over 10%, is the risk for fatal or non-fatal. It's a very high risk for fatal or non-fatal cardiovascular events in the next 10 years. And you can see here, if we have a patient of 40 years old who has a cholesterol level 5 means above 150 milligrams per deciliter LDL cholesterol level, and he is a smoker, just a second, and he is a smoker, he has a medium risk of cardiovascular events if he associates high systolic blood pressure, the same risk as a patient 60 years old, maybe without non-cardiovascular risk factors, who has no hypertensive arterial hypertension. So this is important, and this based on these score charts, we have the categories of patients, the risk category of patients. And you frequently hear about the very high risk. He is a very high risk patient. He has a moderate risk. What does this mean? So in the very high risk category of patients are included patients with any of the following: documented atherosclerotic cardiovascular disease. Either it is clinical or on imaging. And documented atherosclerotic cardiovascular disease includes previous acute coronary syndromes, a patient with myocardial infarction, unstable angina, stable angina, any kind of coronary revascularization, angioplasty, CABG, or any revascularization procedures before, stroke, even if it was transient, and peripheral artery disease. If we talk about imaging, is any significant plaque on coronary angiography or CT scan, multivessel coronary disease with two major epicardial arteries, over 50% stenosis. So any patient with documented arteriosclerotic disease is in this category. Patients with diabetes with target organ damage or at least 3 major risk factors, or type 1 diabetes for a long period of time, severe chronic kidney disease, a glomerular filtration rate under 30 means the patient has a very high risk for cardiovascular events. A calculated score over 10%, as discussed, and familial dyslipidemia with atherosclerotic cardiovascular disease or any major risk factor. So, when we are talking about patients that experienced a myocardial infarction, when we are talking about patients with diabetes, with insulin maybe, or severe CKD, that patients go directly into this category, and we have targets for LDL cholesterol for every category separated, yes? The high-risk patients are patients with markedly elevated single risk factors with total cholesterol levels over 300, LDL over 190, or blood pressure grade 3. Patients with familial dyslipidemia without any major risk factors, patients with diabetes but without target organ damage, or a duration of diabetes type 1 over 10 years, or moderate chronic kidney disease, and the glomerular filtration rate goes up to 60 milliliters per minute, a calculated score between 5 and 10. In the moderate risk category comes the young patients with diabetes without any risk factors and calculated score between 1 and 5, and low risk is a score calculated under 1% for the risk of fatal and non-fatal events. Which are the targets for the treatment and the goals for us in every patient? Of course, referring to smoking, no exposure to tobacco in any form. Diet, healthy diet, low in saturated fat, focus on grain products, vegetables, fruits, fish. Physical activity, up to 7 hours of moderated, vigorous physical activity per week. That is what you should tell patients, or 30, 60 minutes most days. And the effort should be cardio and should be isotonic and not isometric. The body weight, of course, BMI, 2025, index, waist circumference, under 94 in men, under 80 in women, and blood pressure under 140 with 90. And this is an important slide to show you the target. So we have the target for the patients. We have discussed these 2 days, the patients with interesting personal pathologies and atherosclerotic cardiovascular disease. So the goal for LDL cholesterol is always under 55 milligrams per liter, or at least 50% in the first month, at least a 50% LDL reduction from baseline. So these patients require high-intensity LDL lowering therapy, and the first consideration is to use statins, and if it doesn't work, to intensify the regimen to statin and ezetimibe, and then maybe a PCSK9 injection to control the LDL cholesterol. The high-risk category has another target. The target for LDL cholesterol is 70 this time, 70 milligrams per deciliter, moderate category up to 100, and for us, the goal of LDL cholesterol, for all of us maybe, should be under 160 milligrams per deciliter. For triglycerides, it's under 150. And you asked me yesterday about the cutoff of glycosylated hemoglobin, and this is under 7%. We had a lower cutoff in recommendations, but the new guideline for the prevention now says it's 7%, under 7%. Okay, and just 2 more slides about this prevention and goal and so on. We consider statin in high LDL cholesterol levels, and when we want to get to this target, but sometimes we experience some associated symptoms, some side effects from this statin regimen, and you have here the recommendation: we should not stop entirely the treatment, even if the patient has, I don't know, pain in the muscle or is severe symptomatic, but without an increased creatine kinase. It's only recommended to interrupt statin if the patient presents rhabdomyolysis, and then we should try to use another drug, another potent statin in a low dose. If it doesn't work, we should add ezetimibe, and the last resort is to add this PCSK9 inhibitor that binds to the LDL receptor and helps the degradation of LDL receptor and cholesterol, lowering the cholesterol. It's very potent. It's very new, and we can administer this treatment to patients with familial dyslipidemia, in which we cannot control the severe, the increased LDL cholesterol levels. Okay, and now we are getting to the point, and we are talking about something. We have a case, the broken heart. We will see what's all about. A female patient, aged 66, with the dyspnea and orthopnea, who presented in the emergency department for severe thoracic pain for almost 6 hours. Let's do the anamnesis and let's find out what this patient had. Do you hear me?
Yes, I will first ask the patient to keep complaint in her own words, maybe the chest pain and.
Okay, Aline, can you repeat, because I don't know, maybe I didn't hear well, or the connection is not very good.
I hear myself double, I don't know why.
Yes, you have an echo behind you. Just repeat the question.
The chief complaint, so the thoracic pain and the dyspnea, for example, the characteristic of this.
The characteristic of this pain, it was a substernal pain, aggressive pain, and with the radiation to the neck, jaw, and posterior thorax, and that's it. Ask me more. The characteristic, what do you mean? What do you want to know? So how was the pain?
Like the onset, but she said, I think 6 hours ago, right?
Okay, 6 hours ago. was at rest, but induced after emotional stress. And it was associated with anxiety, sweating, and lipopthemia. And what else do you want to know? I told you about the onset.
Was aggressive, so like on 10 scale, on 10.
It was very intense in the beginning, but it progressed and it got worse in the next few hours.
We could ask about her past medical history, like any major illnesses or anything she might have.
Okay.
Had.
She has hypothyroidism, and she's taking the Euthyrox for this one, and she's hypertensive.
Also, any like family members or anything, like if they have any genetic illnesses or anything, or just the health of their family, I guess?
No, nothing important in this area.
Is she a smoker?
She's not a smoker.
Did she had any previous surgeries or something? Or medical interventions in the hospital, big one?
No, she didn't. I cannot remember exactly, but I think she didn't.
And for the medications, only the ones that you told us about now, or any?
Yes, she had medication with ACE inhibitors for her blood pressure and Euthyrox for her thyroid gland. She's a nice, educated woman.
Did we ask how long the dyspnea and the orthopnea has been going on for before she came?
She's worse. She was worse 1 hour before presentation, but the pain started a few minutes after an emotional stress.
What
For 6
cause?
hours.
Do we know what the cause of the emotional stress?
Okay. Her son jumped through the window from the 4th floor, and he got into cardiac arrest, and the ambulance came and they resuscitated him, and finally he died. He was 35 years old.
So all the symptoms she came to the hospital for was recent. It wasn't going on for a while. Is that what you said?
So the symptoms began, the onset was immediately after he jumped through the window, and the pain did not go away for 6 hours, and she was worse and worse and worse.
Could it be like a heart attack or something?
It could be like a heart attack, yes, but we will see. Okay, did you ask anything from the history and so on? I guess you did. Let's
yeah.
go.
We can go to vitals.
I don't know. So symptoms onset after a tragic event, emotional shock. Oh, that's not good. Okay, yes, we can go to clinical evaluation, and we can go to biology. it's not very good that I give you the biology before ECG echo and so on, but in the emergency department, you know, when a patient comes, you do this stuff in parallel, and you talk to the patient, you do an ECG, you have some blood samples, and you immediately have some emergency markers. So that's why I'm giving you clinical evaluation and biology in the same time. Okay, so let's go to some vitals. You say, what do you need?
Blood pressure, heart rate.
Okay, I only have the systolic blood pressure because the diastolic one was not very convincing. It is 76 millimeters mercury, the systolic blood pressure.
So she's not hypertensive?
She's not. In this moment, the moment at presentation, she was not hypertensive. She had 76 millimeters mercury, heart rate 96 beats per minute. What else?
Temperature?
Temperature, febrile, she was not warm. Anything else? Heart rate.
Heart rate, respiratory rate.
Respiratory rate, 27 per minute.
Saturation?
Saturation was 90%.
Diuresis as well?
She didn't urinate for the last 6 hours. No, the saturation was 88%. I'm sorry, I didn't see this. 88%, the saturation. She's not pretty good. Do you agree? The vitals are not very nice. What else? She was dyspneic, orthopneic. What do you ask? What more do you need?
Did she have any edemas or?
She had cold extremities, very cold extremities, and she did not have any signs of systemic congestion.
Mm-hmm.
During the 6 hours, did she faint or had a syncope or something?
Yes, she had a lipothermia. She did not lose her consciousness. But in this tragic scene, it was kind of normal to happen like this. And the retrosternal, substernal pain, it was normal, and her shock was normal, and all of these could be normal in this situation. Okay, you need to auscultate her heart and her lungs, don't you? So she had some crackles bilaterally, basal crackers, and subcrepitants, and she had an LV gallop, and we did not hear any murmurs. I think it's enough, don't you? For the first I don't know, meeting with the patient. So biologically, what do you need in the emergency room? Because you think about a heart attack, you think about something. It's a severe retrosternal pain, substernal debuted, but then retrosternal pain, and you need some markers. How do you establish the diagnosis? Go on, quickly, because you know this.
Creatinine?
Okay, creatinine. I don't have the creatinine now.
Troponin.
Troponin, high sensitive troponin was over 7,000. So the cutoff is around 24. It was high sky, very high, yes.
CKMB.
CK and CKMB. CK is 320, CKMB is 62, twice and a half as normal. Okay, and an anti-pro-BNP of almost 2,000. These are high values. She had a lactate of 2.4 and metabolic acidosis with the pressure of CO2 which was normal. Okay, so what do you think about this patient? You have the clinical examination, you have the anamnesis, you have the markers. What syndrome can you establish for the, I don't know, first opinion? Can you think of something? Heart attack, you said it.
Yes, heart attack.
Be a myocardial infarction. It could have been a myocardial infarction. So it is an acute coronary syndrome. But could it be heart failure? Acute heart failure? It is acute heart failure provoked by something, and we must find out. So when you have such a patient, she is not breathing, she's cold, she has a low blood pressure, she's in respiratory distress because it's obvious she's not good. So the suspected diagnosis for the first time is acute heart failure. And in the urgent phase, after the first medical contact in the emergency department, you should establish if this is a cardiogenic shock or not, and if the patient has respiratory failure or not, because your treatment depends on this. If the patient is in cardiogenic shock, then you need circulatory support, even if we talk about pharmacological one or mechanical circulatory support. What's pharmacological circulatory support? What medication do you know for cardiogenic shock?
Aspirin?
Inotropes, maybe?
Oh, yes. Of course.
Inotropes, because aspirin, yes, you could have loaded this patient with aspirin, but after you first see the ECG and you see some abnormalities and you think this was the consequence of acute coronary syndrome. Okay, if the patient have respiratory failure, it needs another medication. So the first one to be its ventilatory support, oxygen, and of course this patient got some oxygen on the mask, Or if the patient is not does not respond good, you need non-invasive positive pressure, CPAP or BiPAP, or mechanical ventilation, depending on the situation. So this is the first medical contact. You see the patient is critical. Is it cardiogenic shock? Is it respiratory failure? You don't know, or you must know, just to, in parallel, to do the therapeutical management. And in the initial 1-2 hours, you have immediate phase, 2 hours, you need to identify the acute etiology in order to resolve the case. So we have this memo technique, it's CHAMP, acute coronary syndromes. It could be a hypertension emergency. It doesn't seem like. It could be aortic dissection, and with tamponade and low blood pressure. It could be an arrhythmic cause, and you needed the ECG for this. Could be atrial fibrillation with a very high rate and with low stroke volume, or it could be, I don't know, a ventricular tachycardia, well tolerated. Acute mechanical cause. In the setting of acute coronary syndrome, you can have the rupture of the free wall. You can have the septal defect. You can have the rupture of the papillary muscle. What else you can have? You can have severe mitral regurgitation secondary to the papillary muscle rupture. Or P, the last one is pulmonary embolism, which is hemodynamic. Just a second. My battery is running low. Sorry.
It's okay.
It should not happen. Okay. That's it. Okay, or we can have pulmonary embolism with instability, hemodynamic instability. And if something is clear, and if we identify the etiology, we initiate the specific treatment, which can be life-saving. So we are up to the diagnosis workup to confirm the acute heart failure and the clinical evaluation to select optimal management. The patient was in cardiogenic shock, we thought, and the inotropes were administered. What do? We have the bedside assessment. I know it's a very hard case for you, but you should know what's a cardiogenic shock before you leave the cardiology department, in order to have some information about all the pathologies we are dealing with. So you must hear about this stuff in a practical session maybe. So the first to go is the bedside assessment to identify the hemodynamic profile, because the acute heart failure. Did you talk about acute heart failure with Professor Popescu? Did you talk about pulmonary edema and cardiogenic shock?
No, not yet.
You didn't? Okay, maybe you will talk this into treatment, I don't know. Okay, the first to assess is the hemodynamic profile, and we will talk about this profile. The second, assess congestion. Did this patient have any congestion? We have a wet or a dry patient. You had the clinical evaluation. You know
A
what
dry
was-
patient?
We don't have a dry patient. She was a wet patient. Why? because she did not have congestion, systemic congestion. She did not present pedal edemas, but she was wet in her lungs. You
Okay.
heard crackles, you heard some crepitants, she could not breathe, she desaturated, so she was a wet patient. And 95% of all patients are wet. So you identify the hemodynamic profile. No, you didn't yet. No, the first one, this is a mistake here. So the bedside assessment, 2 minutes near the patient. The first one is congestion and the second one is peripheral perfusion. I did it wrong, not you. Okay, so wet patient, what do we need to know? We need to know more in order to establish the treatment. We need to know the perfusion. Was this a patient with a good or a poor perfusion?
I think
Poor.
was close.
Poor. What in her clinical examination that can gives you the information that this patient was hypoperfused?
Temperature. She had cold feet.
Cold feet, great. So peripheral hypoperfusion. She had no diuresis. She was anuric, and she had what else? Low blood pressure, I told you, and she was anxious, and she was not very conscious, but she was in emotional shock, so you cannot tell more about the neurological abnormalities. Okay, so she was a hypoperfused patient. Adequate peripheral perfusion? No. We have this type of patient. She is wet and cold. It is the most bad profile of all, with systolic blood pressure under 90. Yes, so she needed inotropes, vasopressors, and so on, maybe circulatory support, if no response to drug. It is not very important for you, the treatment. I just want you to know how we are dealing with these cases and what's the medical judgment for these cases. So we have some profiles here, 2 minutes bedside clinical profiles of patients with acute heart failure based on the presence and the absence of congestion and hypoperfusion. In here we have congestion, and here in this line we have hypoperfusion. And this is the most healthy patient, which is warm and dry. And if we go back, if the patient is dry and if the patient is warm, he has no hypoperfusion, this patient just needs the adjustment of oral therapy. So it is the most healthy patient we can have in the emergency department. But if the patient does not present congestion and present hypoperfusion, he is called hypoperfused and dry. He has no congestion. We have the third situation in which we have congestion. This can mean pulmonary congestion, as in our case, orthopnea, paroxysmal nocturnal dyspnea, so symptoms of heart failure, peripheral bilateral edema, jugular venous dilatation, congested hepatomegaly, gut congestion, ascites, and hepatojugular reflux. This all means congestion, any kind of congestion, pulmonary or systemic. So he is a wet patient and he's not hypoperfused, he is warm, This one here is the classical pulmonary edema, the classical acute pulmonary edema. And we have two types of acute pulmonary edema. This one here, wet and warm, with typically elevated or normal systolic blood pressure. This one here is not in cardiogenic shock. And we are dealing with two kinds of patients. The patients with hypertension, they come with high blood pressure, 200 millimeters mercury, and they are in pulmonary edema, and it is very easy because you can give them nitroglycerin IV continuously and diuretics. So the first to take into account is the vasodilator, and these patients respond well to the treatment. The second type is the type where the congestion predominates, and this type of patients respond well to diuretic therapy and then vasodilators. So this one here is the profile of acute pulmonary edema. And the worst of all is cold and wet. You have the congestion, all signs and symptoms of congestion, and you have the hypoperfusion. Hypoperfusion means, as signs, cold sweated extremities, oliguria, mental confusion, but in this case, it was very hard to establish the cause of mental confusion. After your son dies, you cry along with the patient, so it is hard. Dizziness might be from central nervous system hypoperfusion, and narrow pulse pressure. Narrow pulse pressure means insufficient preload leading to reduced cardiac output, and maybe an increased systemic vascular resistance. So narrow pulse pressure. We don't have the diastolic pressure to say what was the pulse pressure in this patient. Okay. And this one here resembles the Forrester classification. I don't know if you have it in your book or in your courses, and it was very nice. You know here that here is the cardiac index. So all these here, type 1, warm and dry, and type and this type, the acute pulmonary edema, have a cardiac index, a normal cardiac index over 2.2. These two here with hypoperfusion have a low cardiac index under 2.2, and under 2 is critical because the patient cannot support the cardiac output without any help, without circulatory help with inotropes or mechanical ones, and so on. Okay, it is not very interesting for you. So let's establish which was the profile for the patient we are talking about. Which was the exact profile?
We said it was warm and wet, right? Didn't we?
We said
Cold and wet.
Cold and wet.
yes, cold and wet. She was cold in her feet, wet in her lungs. Cold and wet. She was in cardiogenic shock. Okay, what does this mean? Implies the loss of pump function of the heart with severe contractility dysfunction, a reduction of the heart's contractility with low cardiac output, and we have some diagnosis criteria. The systolic blood pressure could be, but it does not have to be exactly like this, under 90 milli. Just say it. millimeters mercury in normotensive patients, or a reduction of mean arterial pressure with more than 30 millimeters mercury in hypertensive patients. We have another criteria, diagnosis criteria, which refers to systemic hypoperfusion, a cardiac index under 2.2, and if you cannot calculate this in the emergency department, you should look for signs: obnubilation, central nervous system hypoperfusion, hypoxemia, referring to the lungs, oliguria, renal hypoperfusion, cold extremities from low hypoperfusion in the peripheral arteries. Hepatocytolysis is the shock liver, as we know it, is the liver hypoperfusion, and increased lactate levels over 2 millimoles because of the base deficit or pure lactic acidemia, a consequence of the low tissue perfusion. Okay, we didn't get very far. We know until now that we are dealing with acute heart failure, and we are dealing with cardiogenic shock. And I wanted to show you in this slide that in the first case, the mortality is rather small, under 3%, but this one here has a high mortality. 1 of 2 patients dies. So when we are dealing with cardiogenic shock, it's a real emergency. The patients with pulmonary edema, which are warm and wet, they die, but the mortality is around 10%, so then they can be saved rather easily. What investigations do we need to establish the diagnosis?
ECG?
The ECG, great. What else?
Echo as well.
Great. Go on.
Maybe an X-ray for the lungs?
Maybe, yes, for sure. The X-ray is mandatory. So in all patients, just ask for the X-ray. It's mandatory for all. But if it's, I don't know, such an emergency, and we kind of know what we are dealing with, we can decide for an X-ray, not in the first minutes, but later on in the ICU, ICCU, I don't know, depending on the patients. But you should ask always for the pulmonary radiography. Yes. Okay, let's go with the first investigations, and then you tell me what we need more, if we need more. So this is the ECG. Can you help me with this ECG? A disappointing ECG.
Heart rate around 75. It looks regular.
Okay, do you see P waves?
Kind of.
You see P waves, yes. Here is a P wave, here is a P wave, P wave, P wave here. Yes, we have sinus rhythm. Sinus rhythm, 75 beats per minute. Axis.
Looks normal.
It looks normal, okay.
That's why it kept, like, I couldn't sleep because it kept vibrating. I don't know how you did feel it.
Go on. You know this. It's easy for you. Just say. Anything.
The PR is a little bit increased.
Okay, I agree. I don't see very well the squares, but 4, 5.
Oh my god, what happened?
Melina started saying, "Oh, it's not okay, guys. Don't come online.
Abdul,
I'm sick of your bullshit, all of you."
Abdul, your mic's
has
on.
the mic
And
on.
then Munir told her it's not mandatory. Like she had beef with Munir and she removed it.
Abdul, your mic is on.
Okay, let's go with the abnormalities here. It's a nice ECG, but it's not how we expect it to be.
Is it ST elevation in lead
ST
1?
elevation. Yes, describe this ST elevation. Can you? Where is it?
I see in lead 1.
Lead 1. Okay. And
Is it subacute?
sorry. If it's subacute, you said?
Yeah? Or acute? I don't know.
Oh, we will see. So you see here an ST elevation. Where do you have to look if we see here, if you do see it in D1? You have to have the ST elevation in at least two contiguous leads that look at the same territory, yes?
AVL also?
AVL, okay. Do you see it in AVL?
Yes.
Yes, you do. If you have it on in D1 AVL, you should look where? Then, for the lateral territory.
V5 and V6.
V5 and V6. Do you see it
Yeah.
in V5, in V6? I
No.
don't really see it, but it doesn't matter. You have it in two contiguous leads, D1 and AVL. How does this ST elevation look like? It's a smiling face or a benign? It's a benign modification, or it's the sad face. It's with upward concavity, yes. It's not very specific for a myocardial infarction with ST elevation, for a STEMI. It could be. It seems like early repolarization or myocarditis or pericarditis, myopericarditis, but it's not really specific for an infarction. But
Can be
then
an Osborne wave or something.
if can be, oh, I cannot see the hump here. But the patient was not, her temperature was normal. It was not 32 degrees. She was not staying in cold and she was not hypothermic. So no, it could not be an Osborne wave because she had no clinical no context for this. She was not in hypothermia. Yes, you can think about this, but this is a notch here, yes, and an ST elevation. Okay, but it is another important thing that we couldn't interpret very nicely. And in this case, in a severe patient and in cardiogenic shock, we went for another investigation. This one here, the ST depression with the T negative in D3. It could be something mirror of the lateral wall. It might. We didn't know in the emergency department. So we have this elevation here and not more. We thought about a lateral, maybe event. We thought of myocarditis. We thought of something. Let's do the echo and we'll see. So the echo in the emergency department doesn't look very, very nice. Is there something that you see when you are looking at the 4 chambers view? What is this one here? You did
Left atria.
left atrium. This one is the right atrium, right ventricle, left ventricle. Yes. And when you look, I know it's a poor image, but poor quality. But if we look at the contractility, what do you see? Do you see a normal LV?
Similar.
Akinetic, the tip
Yes.
of the left ventricle.
Yes, yes. Here, apical septum. This is the ventricular apex. Yes, and this one here until his half is the anterolateral wall in 4 chambers view. So we have apical akinesia and hyperkinesia of the basal segments, because you see the endocardium here that is normal and it's contracting well, but the cardiac function is poor. A left ventricular ejection fraction is around 25% estimated in the emergency department, around 25 and not more. Let's see some other. This is a 2-chamber view. I'm sorry for this. You see the ventricle, it does not contract well. It is obvious that it's not working well. This is the inferior wall, ventricular apex, the anterior wall, and this one here is the left atrium. So only this part, 1/3 here and 1/3 here, are normal. The rest of the ventricle is just stunned. It's staying. It's not contracting. Yes? Okay. Let's go further. Oh, 3 chambers view, we cannot see anything, but this is the posterior wall, and you have to believe my word. This is the ventricular septum anterior, and it's not moving. And this is the apex. This is the apex, and it's awful. And the ejection fraction is poor, poor, poor.
I
Okay.
have a question.
Yes, yes, yes.
Can we think, for instance, of something like Takotsubo or like a diagnosis,
Yes,
like a differential one?
yes, you can. And was the question, and this one was the next question. What do you think? Okay. You just took the magic from us. Okay, you're right. And it might be a Takotsubo, but let's see how we establish the diagnosis. We thought about Takotsubo because she was a female patient and just went to this tragical event, and which I cannot, I don't know, it's awful. So about the ejection fraction, I don't know what to tell you. You did echo. What did they tell you? What's the normal ejection fraction? What's the normal LV ejection fraction?
60.
60, great. You know of 60, it's okay. So over 55 and some of the British Society of Echo, the Old British Society, the Americans, which are good, the Europeans, which are very good, the Heart Failure Society is this one, and another Americans, the College of Cardiology, all think that over 55 is the normal cutoff for the ejection fraction. If you know 60, it's okay. Over 50 is preserved ejection fraction, but it's not normal. Not normal in here either. It is preserved. Okay, but you see there are many opinions. We think that under 40 the ejection fraction is low, so we have a severe LV dysfunction, but the opinion is that under 35, maybe under 30, we can tell about the severely abnormal function of the left ventricle. So it is not quite, we don't really know, but we use this cutoff of 35%. She had severe ventricular dysfunction. And we think about all these factors that are triggering acute heart failure. And let's do this list together in order to establish what could be the diagnosis. So could it be acute coronary syndrome? Do we know? It could be. What do we need to find out? We have markers. We have troponin, we have CK, we have CKMB, we have echo with regional wall abnormalities in the anterior and apical segments. So we have what it takes, and we have an ST elevation in D1 and D2. It is not very suggestive for myocardial infarction, but we cannot exclude acute coronary syndrome. So what do we need to establish the diagnosis? We need something more. Tell me quickly, because you know.
Angiography?
Yeah, of course, angiography. In the, I don't know, first 15 minutes, rapidly, immediately, angiography. Tachyarrhythmia. It was not atrial fibrillation, it was not ventricular tachycardia, it might have been, but we didn't see anything. Excessive rise in blood pressure, that was not the case. Infection, pneumonia, endocarditis, sepsis, we did not have the markers of inflammation. The markers were normal, but I forgot to tell you about these ones. Non-adherence with salt, fluid intake, or medication, it is not the case. Bradyarrhythmia, toxic substances, alcohol, restrictional drugs. You didn't ask me this when we got through the anamnesis. Drugs. You have to ask about drugs. You asked me about drugs. Exacerbation of chronic obstructive pulmonary disease, it is not the case. Pulmonary embolism. What about pulmonary embolism? Why didn't we think of pulmonary embolism? Because the right ventricle was normal, and because we had normal D dimers, and we have no echo findings suggestive for right ventricular dysfunction. Surgery and perioperative complications, no. Increased sympathetic drive, stress-related cardiomyopathy, this is very nice and could be. Metabolic derangements, thyroid dysfunction, but not leading to cardiogenic shock unless it's something very, very severe. Cerebrovascular insult, the patient had no markers for a stroke or acute mechanical cause, and we just excluded these etiologies on echo. Myocardial rupture complicated an acute coronary syndrome, free wall rupture, ventricular defect, acute myocardial, acute mitral regurgitation, we talked about these ones, endocarditis, aortic dissection or thrombosis, and a tamponade, of course. So we have the acute coronary syndromes, we have the stress-related cardiomyopathy, and we could have something like myocarditis. Do you agree? Okay, how can we establish a diagnosis of myocarditis? What do we have to have? We have to have pain, okay, we do. We have increased biomarkers of cardiac necrosis. We do. We have some wall motion abnormalities. We do. What do we need? We have to have some ECG changes. We have. Why this is not a myocarditis? What do we need? An angiography, yes. It's an exclusion diagnosis. Did you go through the course of myocarditis? Did you learn about myocarditis or not? Yes, no.
Yes.
Okay, so angiography. We need angiography to establish the diagnosis. So myocarditis, STEMI, or Takotsubo, we didn't really know, but until we get to the coronarography, we must know that therapeutic management goes along with searching the etiology for every patient that is so severe. So this is the coronarografia, because it stays in Romanian like this. What's this artery here?
The right one?
The right one, great. The right one, which was normal, and I don't expect you to tell me about the stenosis because there aren't, and because it is very hard to see unless you are very experienced, or you have to just stop the film. And this one here is the LAD and the circumflex artery, and these two were normal, the common trunk, and these two were also normal. So the patient had normal coronarography. What do you think about this? About the normal coronarography, what could it be? So we found out that this is not a STEMI, or if it was something, the ST elevation just dropped and the vessel was reperfused, but it could not make such a severe systolic dysfunction unless big amount of thrombus was seen in the coronary artery. So this one was excluded. The STEMI diagnosis was excluded after coronarography. Could it be myocarditis? Yes, no. It could be, but we have no inflammatory markers, and we do not have something in our anamnesis. We don't have viral infections. We don't have any infection. We don't have a suggestive anamnesis for this kind of diagnosis. And what we do and what we have done with this patient, okay, maybe this is hard to you, but just to know, we have the mechanical support for the heart, and the first one that we have is the intra-aortic contrapulsation balloon that was implanted in this patient. And because the diastolic blood pressure is the main important determinant of coronary perfusion, this device might help. So you take this device, and it is a balloon that you are placing in the cath lab into the descending thoracic aorta. And in systole, you deflate this balloon in order for the blood to be ejected from the ventricle through the aorta and then to go into the periphery. In diastole, you inflate this balloon in order this blood to perfuse well the coronary arteries, in order to reduce afterload and increase cardiac output and coronary perfusion. So this is an augmentation of the diastole, and this is why this device could be life-saving in the first days, together with inotropes and vasopressors in cases of cardiogenic shock. It is too much, but just to hear it exists, intra-aortic contrapulsation balloon, Impella, and other devices that could be life-saving. And this is the balloon that is showing here in the descendant aorta, and we must take these radiographies after implantation to see it's well positioned. Okay, we have normal coronary arteries, we don't have STEMI, we don't have myocarditis either because of non-significant anamnesis, normal inflammation markers, and we are here with our Takotsubo syndrome. Congrats for this diagnosis. What does it mean? What do we do for the patient, and how do we treat the patient? So let's go. This is the stress cardiomyopathy, the Takotsubo syndrome. You can find the name, the broken heart syndrome or apical ballooning syndrome, and it consists classically as transient hypokinesia, akinesia of the ventricular apex, and compensatory basal hyperkinesia in the absence of coronary artery disease. And the name comes from taco, octopus, and this tsubo, which was a trapping pot, a Japan trapping pot. This is the name coming from the shape of the ventricle with apical ballooning, resembling the trapping pot. This is the systolic phase, apical ballooning. This is the diastolic phase with the dilatation of the left ventricle. We can have more types, 3 types of Takotsubo, but the most frequent one is the apical one, and mid-ventricular could be in men that are young, but this apical one, over 80% in women that suffer from an emotional stress. And the pathophysiological mechanism are not well understood. The emotional stress or physical stress, even when we talk about negative or positive emotions, because we have the happy heart syndrome, so it's not very good to be very, very happy. So because it can do exactly the same thing, the cardiogenic shock from Takotsubo. Even if we talk about natural disaster or intoxications, trauma, surgery, drug, you have it all here, the triggers, the emotional triggers and the physical triggers. That leads to excessive catecholamines, or might be the dysfunction of the microvascular dysfunction, or a vasospasm to cause this transient condition. Okay, in hospital complication could be many, and it is the prognosis is similar with the prognosis patients with STEMI have, and the mortality could be around 60%, over 50%, so it's a high mortality rate. The patient was admitted in the ICU for non-invasive pulmonary support, systolic blood pressure of 90, severe metabolic acidosis, as we said, and she had a cardiac index of 1.4. So she had a very, very low perfusion. A cardiac index under 2 is very, very bad, just it. Okay, we have some therapeutic options. We have all the inotropes, and from this list, we have the inodilators too. I wanted to talk to you not about this kind of medication because it might be hard to understand right now, but does this patient need anticoagulant? She's in the ICU bed. Let's think about the treatment. We didn't know what treatment to give her for the first couple of minutes, but then we began to think. So let's think together about the treatment. Does this patient have any indication for anticoagulation? Yes, no. What are the indications for anticoagulation? Let's talk, well, short talk about anticoagulation. When do you use anticoagulants?
Previous history, for instance, of an embolic event. Great.
So if in cases of embolism, thromboembolism, or profound femoral, I don't know, venous embolism, yes, you can do that. Great. And some other reason for going ahead with anticoagulants? You have the main one.
Risk factors?
No. No, so just separate yourself from this case. Just think about when you can use anticoagulants. In what kind of patients? Embolism, yes, previous embolism or current embolism.
After surgery?
After surgery, perioperative, but in prophylactic doses, yes. That is just to prevent the embolism. Yes, you can do that. And when a patient is in ICU, we do this all the time because the patient is cannot mobilize himself, so he's staying in bed all the time. We need the prophylaxis with the anticoagulation. You're right.
Mechanical valves?
Mechanical valves, a very nice one is this one. Always anticoagulate mechanical valves. And the most common indication for anticoagulation would be
atrial fibrillation.
Atrial fibrillation. Great, this is. But why do we anticoagulate patients with atrial fibrillation?
Because of the stasis.
Okay.
So we activate maybe the factors.
Okay, because it could be some clots in the auriculum, left one, and then they go into your head and provoke stroke. Yes, this is the main reason for the anticoagulation, stroke prevention. Stroke prevention. Okay. Do we have to take into consideration anticoagulant in this patient, our patient? She's staying in bed. Yes, prophylactic anticoagulation. We can do that. Beta blockers. This is nice. Beta
no.
No. Why not?
Because we increase the oxygen need.
Okay. What else?
And the heart already is, the apex is akinetic. And we reduce the heart rate more.
Okay. It might be helpful to reduce the heart rate, because if we reduce the heart rate, we may increase the stroke volume, but we cannot give beta blockers because this patient is in respiratory distress and needs non-invasive ventilation, and we cannot do this. It is the main contraindication for the beta blockers, not when we have pulmonary congestion, not when we have severe ventricular dysfunction acute. pulmonary edema, yes? So no in pulmonary edema, no in pulmonary congestion. Can we give this patient ACE inhibitors or statins? In this moment?
Yes.
We can. Yes, we can. But you know, the blood pressure is around 76, the systolic blood pressure. It will drop to 50 maybe. No. So this patient needs a vasodilator, you are right, but we cannot use ACE inhibitors or statins. You just can't, because the blood pressure is too low and the hyperperfusion is too low, and you can't. Do we take into consideration aspirin? So aspirin. It's not harmful. If we don't know, we might give a dose of aspirin. Okay, and because we didn't know in the first 24 hours whether this is a type 2 myocardial infarction, but it was clear, suggestive for Takotsubo, we gave a dose of 75 milligrams of aspirin daily. Statin. Do you think statin was important to be in her treatment? Statin, could it be helpful?
Isn't statin for like prevention? Wouldn't it, at this point, you wouldn't give it to her?
Statin could be in primary prevention or secondary prevention.
Okay.
So, yes. It's helpful or not. It is not important because the patient is in cardiogenic shock and she should receive inotropes. Yes, inotropes, and between inotropes we thought of the latest, which is levosimendan, which is a calcium sensitizer that inhibits the phosphodiesterase 3, and it has the effect of increasing the contraction and improving the cardiac output and vessel dilatation. So it has two good effects. We can give this kind of therapy to patients in Takotsubo in which the myocardial stunning is seen with very, very nice results, and we gave levosimendan. But tell me more about antidepressive or anxiolytic treatment. Is it proper to use this kind of treatment in this patient? It's an easy one. Yes, of course, she suffered an emotional shock. She's crying all the time. She cannot get better until we resolve this one too. Besides levosimendan and milrinone, which are the latest, we have the classical ones, the inotropes. Just a second. Sorry. Just a second. Dobutamine, dopamine, norepinephrine, and epinephrine, and you will talk about this medication in your courses with various effects on the inotropism, some effect of vasoconstriction here for the dopamine and norepinephrine. These two, norepinephrine and epinephrine, are vasopressors, and they are used in low cardiac outputs, and when the patient presents also low blood pressure besides low contractility. Okay, after levosimendan, do you see something different? This is the apex here in your right. This is very nice. The apex is very nice. It's contracting, and the ejection fraction has improved. You now see the endocardium here. It's not stunned anymore. Of course, the patient has does not have a very good ejection fraction, but it is clearly that something good happens. Other markers of improvement, the cardiac index was higher, 2.5, normal diuresis, left ventricle ejection fraction of 35%. I could have told that she had 40, and in day 3 the intra-aortic balloon pump was weaned. Okay, the hemodynamic evolution was very good. It's not important for you. And at the discharge, the patient looked like this on echo basis. So we were very happy because she has made it through this particular event with an ejection fraction of almost 45%. You can see the endocardium here, and it is not normal kinesia, but is hypokinetic and not akinetic anymore. And she was good. If the ventricular dysfunction persisted, we would have needed cardiac magnetic resonance for establishing the type 2 myocardial infarction with normal coronary arteries. And this type of infarction refers to some mechanism that imply the oxygen and the oxygen supply and demand imbalance. When we are talking about fixed coronary arteriosclerosis, spasm, embolism, coronary embolism, when we are talking about coronary artery dissection, sustained tachyarrhythmia, severe hypertension, it's the example of the patient that comes with acute pulmonary edemas and increased biomarkers. In cases of severe bradyarrhythmias, respiratory failure, anemia, and hypotension, we can have type 2 myocardial infarction with normal coronary arteries. The treatment at discharge was bisoprolol, beta blocker, ACE inhibitors, because we can now in the chronic phase, we can give ACE inhibitors, and we should, first of all, for the hypertension, secondly, for the reverse remodeling of the LV. Atorvastatin, because she had an increased level of LDL cholesterol, and now we must hit the target of the very high-risk patient of 55, alprazolam and Eutirox. The cutoff for the Takotsubo of LDL cholesterol, of course, we don't know. Follow-up, this is the apex after a while. Left ejection fraction, 55, normal segmental kinesia, normal BMP, no signs of heart failure, no symptoms of heart failure, and we are dealing with asymptomatic patient. Okay, so do not haunt the octopus. This was a hard case for you. I don't want you to know what to do with this kind of patient, but I want you to know what a shock means, a cardiogenic shock means, and how you can get to the diagnosis, and how can you approach how you can have a stepped approach to get there. This is the main reasons we are presenting you these cases. Okay, this was fast. I didn't prepare anything for you today. We might have some cases tomorrow, some ECG cases, shorts. ECG cases, maybe a full case, maybe a valvulopathy. I will think about one. And on Friday, we are talking very shortly about narrow QRS tachycardias if you want to, and then we will see. I don't know. Do you have any questions? Did you have your coffee?
Yes.
Yes. Okay. What course is for today? What's the
I'm not sure.
name of the course? I don't know either.
Maybe the one we were supposed to do yesterday. The
Maybe
treatment.
it would have been